Good morning, everybody. Welcome to another episode of Treat IR Live. We have a great case of prostate artery embolization for you this morning. Before we go to the room, I'd just like to thank BroadMed AV for making this possible, as well as our patients who are the cause of main reason why we're doing this. All of our faculty, techs, staff, nursing staff, as well as all of our partners doing this. So thank you, everybody, for making this possible. And then I am accompanied by two great co-moderators today. I'll start by introducing ex-Sinai fellow, Sinai alum, and IR guru, who is an interventional radiology at Charlotte Radiology, Jeremy Kim. Jeremy, good morning. Thank you for being here with
Good
us.
morning. Thanks
And
for having
then
me.
also former Sinai faculty and director for prostate cancer at the Cancer Institute in Northwell Health, Art Rastinehad. Art, good morning. Thank you for being here.
Good morning. Excited to be here with everybody.
Awesome. Well, in terms of the case and the moderating, I think we're going to have a great session for you and discussion. So I am going to now send it to the room. I think we're ready. Dr. Aaron Fischman and Dr. Vivian Bishay will go ahead and take it from here.
Good morning, everyone. You guys hear me loud and clear?
Loud and clear. Go ahead.
All right. We're here in room 1 over at Mount Sinai Hospital. It's my pleasure to introduce this case for you guys today. Before we start, I wanted to quickly thank our nursing and tech staff, as well as BroadMed AV, for providing this amazing feed for us today. I'm here with my colleague and partner, Vivian Bishay, as well as our PGY6 resident, Sid Kulkarni. And Sid is going to show you guys our case presentation today, and then we'll get started.
My name is Sid Kulkarni. Today, our case is of a male with benign prostatic hyperplasia with urinary retention. So he's an 89-year-old male. He has a history of carotid artery disease, chronic kidney disease stage 4, CAD, hypertension, hyperlipidemia, OSA, history of bladder calculi, and BPH. He's been experiencing lower urinary tract symptoms for over 20 years, including incomplete bladder emptying, frequency, intermittency, weak stream, and nocturia. He says he wakes up 2 to 3 times a night for almost 2 decades now. He's previously underwent a microwave ablation many years ago, as well as a TURP about 5 years ago, but he still continues to have these lower urinary tract symptoms, and he's taking tamsulosin and finasteride every day. 1 week ago, our patient actually went into urinary retention and now has a Foley catheter in. So when we saw him in our office hours on physical exam, he was pretty benign on his labs. You can see he has an elevated BUN and creatinine, as well as a low GFR, which is consistent with his history of chronic kidney disease. Whenever we evaluate any of our patients in our office hours for a prostate artery embolization, we always try to assess the level of how bad the retention or their symptoms are. So we use the IPSS, which is the International Prostate Symptom Score. And the score goes from a 0 to 35. This patient scored a 17, but this was before he went into retention, as well as his quality of life, which was a 5, 6 being the worst. So he's pretty unhappy with the symptoms. Before we perform this procedure, we always like to get a planning CTA to kind of look at the anatomy to see if we can see the prostatic arteries. Given this patient's renal function, we did a non-contrast CT, and we can see he has a Foley catheter in, as well as a very enlarged prostate. Yep, so his prostate's measuring almost up to 7 centimeters in one of the dimensions. We can see there's definitely some intravesicular extension. He has a Foley in, so he has severe BPH, now in urinary retention. Next slide. So in assessment, this is an 89-year-old male with severe BPH, lower urinary tract symptoms, now presenting with urinary obstruction, requiring a Foley catheter for a week. He's previously failed medical and surgical management. He has a very enlarged prostate, so our plan today is to perform a transradial prostate artery embolization. And for these patients who have urinary retention with the Foley in, we usually do a follow-up in 3 to 4 weeks for a voiding trial and possible Foley removal.
Thanks, Sid. If you guys want to focus quickly on the wrist, we're just going to show you what we've done so far, and then we'll get started. Take a look at the wrist here. We have a 4-5 glide sheath slender, which we place in the left radial artery, and then through that we have a 130 centimeter penumbra burn tip diagnostic catheter. So we very quickly got down the arch using just a Benson wire, and we did a quick angio of the common iliac artery on the right side, which is where the catheter happened to go first. And we saw a little bit of atherosclerotic disease. Again, we didn't have a contrast CTA, which we typically like to get, but with a CKD patient, we avoided it in this case.
Now we can.
All right, so we have a little bit of atherosclerotic disease. at the origin of the internal iliac on that side. We used a soft glide wire, which navigated very easily into that. And then we did an angiogram. We loaded the injector with 70/30, so this was about 10 cc's of contrast. So we're just trying to keep track of how much we're using in this patient, and we see very, very clearly the prostate artery. I don't think you need a medical degree even to see this potentially. So one of the interesting things about this particular angiogram is we have a very diseased pudendal artery, which is on the back side here, which you guys can see. Let's pull that up. We're going to draw on the screen. We're going to do some fancy stuff with our new room. This right here, this artery here is the pudendal artery. You guys can see that. Very diseased, which is not atypical for an 89-year-old, right? And then higher up, we have a couple branches off that common trunk there, which is right here. This artery here, the umbilical artery, and then this artery here is a very large prostatic artery. Let's see if I can do that again. There we go. So we're pretty sure that that's the prostate artery. I don't think there's any debate there. And you can see all of those branches going to the prostate, which hopefully we'll be able to demonstrate in a few minutes. So, Jeremy, Art, Girema, what do you guys think about this case so far? Any comments, concerns, things to talk about? Let's grab
My first question would be, how did you decide on your base catheter first? Because I think that's a common
very
question
good,
people
Jeremy.
ask.
I was going to ask the same thing.
I always use that catheter
There's
from a
different
radial
options.
approach to start, and there's a couple reasons for that. The biggest reason is that I think it's very torqueable. It's sort of a great combination between something soft and something very torqueable. So I like that for radial access. You guys can take a look at our wire shape here real quick before we put it in. If you could just focus quickly on the wrist, you can see this this curve has two angles on it. The first curve is a standard curve, and then we usually almost use like a question mark type shape here, and that's generally pretty good for getting into these arteries. The other thing about this catheter is it's 130 centimeters, and so you can see how much we have to work with here. So if we needed to actually put this catheter a little bit further into the vessel, which we sometimes have to do, we're going to have a fair amount of room there. So sometimes we'll use a 125 centimeter catheter, but that's going to be almost hubbed in some patients, and so we like the length of this quite a bit. What do you guys use for radial access? I know, Jeremy, you do primarily radial access. Art as well. What do you guys like to use?
I started with this catheter years ago, and the reason I liked it, because if you're using a liquid embolic, it has a tapered tip and a glide tip, so you don't have a gap when you remove it over your Benson wire, so there's no chance that there's any debris that can be stuck on the tip, and the torqueability is amazing.
Yeah, I bounce around a little bit. I have used the MG quite a bit in the past, but as mentioned previously, the torqueability is important when you're coming from a radial approach, and I think the catheter you're using now is helpful. I also use the Merit 135 centimeter catheter, Berenstein shape, also kind of has a similar profile in terms of torqueability, but I think that's an important concept to note.
Okay,
Aaron,
so
what do
we
you
very
use?
quickly got into that artery. Did you guys see the live fluoro? Yeah.
Yes, we did.
Say that again, Jeremy. I didn't hear what you said.
Yeah, so I was going to ask you what microcatheter you chose, and how do you choose your microcatheter depending on the anatomy?
Yeah, so I was going to ask you guys before we did this, but we wanted to just keep working while you guys were talking. But we picked to start, and we picked a Sniper microcatheter, which is obviously the microcatheter with a balloon tip, and we'll show why we chose that in a second. Sometimes with these angles, it can be challenging, but we were able to very quickly navigate through that long trunk. So, would you guys classify this as a type 1 artery?
I probably would.
But
Yeah.
But it's not coming off the vesicular. Wouldn't that make it a type 2 possibly? That's like, because you called it a common trunk, but it has a pudendal, vesicular, and a prostate.
Yeah, it could. I don't disagree with you, Art. I don't think it really matters. But the bottom line is we see a very large artery with a long trunk. And so if we see something that looks relatively straight, we like to try to use a balloon tip if possible, because we're going to get a little bit better penetration, which I know both of you guys feel very strongly about. That improves outcomes, and we can talk about that in a second. The first thing we're going to do before before we do anything else is inject some nitroglycerin, which we have mixed up already. And so this is a combination of, we're going to give 200 mics of nitro as well as 2.5 of verapamil. So we're going to give a little vasodilator here, and our patient's a little sleepy right now, but typically they feel this and move, or they'll describe the sensation that they feel burning in the tip of their penis, and that confirms for us that we're in the right spot. If they feel it in their rectum, we know we're probably feeding some rectal branches, and so it's a nice way to get a sense of where the arteries are feeding and what you're dealing with. But this is very obviously prostate artery. You can let that run play a little bit, Viv. See if we can play that again.
Aaron, if you don't mind.
Yeah, go ahead. Go ahead,
So
sorry.
Jeremy and it seems like, a lot of the success when you're starting off or when you're doing prostate artery embolization, it's going to be your setup, right? What catheter are you picking? So Aaron is talking about using a balloon microcatheter. Are you routinely using that as well? Or what other microcatheters are you using in your practice?
Yeah, I don't routinely use the sniper. I do, just like what Aaron's doing right now. I like to look at the anatomy and see what I'm dealing with first. If I don't use the sniper, I'll use the lambda microcatheter. I think it's a good intermediary length that I like, so you can still deploy coils. The other thing to consider too is, like, in this anatomy, it's relatively straightforward anatomy. The areas where you get complicated is when you have separate origins of the prostatic artery on the same side, and if you need to embolize multiple vessels and maybe have to do some advanced flow diversion techniques, sometimes using the sniper can be an issue if especially you're going to use liquid embolics. And so these are some of the things I consider when I'm trying to decide what microcatheter to use.
Great. Art, any comments?
I use the sniper as much as I can if it's available, just because I think you get better penetration. But the 2.1 French makes it difficult, as Aaron said, to navigate those sharp angles. So you really have to have a lot of lead on your wire if you're trying to straighten out that vessel to get in. I used to use the Microvention 1.7, which I thought you get anywhere, but I've recently switched to the Lambda because there's a less kinkage at the tip, so you could float in and get a little bit more distal when you want to without putting the wire back in. But Fischman is pointing out something that you have to be aware of on the screen, which, especially if you use a balloon and flow redirect, be conscious of. And the only thing is that when you do the vasodilators, the original papers all said over 3 to 5 minutes. None of us are patient enough to put it in, but Dr. Fischman?
Yeah, so looking at this angio, we see a couple different things. We see dense opacification of the prostate, but we also see this vessel going to the bottom, which looks like a rectal artery, right? I mentioned before he's a little sleepy, so he didn't tell us anything about the nitro that we gave. So my question for you guys is, how would you deal with this? Now, we don't have the balloon up. We obviously could get further into the vessel potentially, but it looks like there's a lot of branches that are going to the prostate a little bit more proximally, so we don't necessarily want to go too far in. We could do balloon inflation and see if we can sort of redirect the flow more superiorly and medially into the prostate, or we could potentially try to coil that branch. There's lots of different options here. What would you guys do? Would you just embolize from this spot? Would you repeat the run? What do you think?
Jeremy, I'll start with you.
I would try to do. Yeah, I would start with the run with the balloon up just to see if that changes the flow dynamics. Otherwise, I don't have a lot of confidence that the sniper could track down that branch to coil it. I would honestly still feel comfortable gluing it from that position, just watching it glue, because you can control the glue in terms of how far it goes into that branch, wait for it to solidify, and then you can kind of push the rest of it centrally towards the gland.
Art, any comments about that?
I do the same thing. I would put the balloon up, take a look and see how the flow direct. That's a big difference between particles and a liquid, is that you have a visual endpoint. And I think that's really changing the whole game in PAE. How long do you wait for it to solidify? I usually say come out quick in the beginning to get some distal flow and then back off and wait. And it's a fine touch of how hard you push the liquid in.
That's beautiful. So that's exactly what we did.
Yeah.
So you guys saw the balloon going up. We put a very small amount of 50-50 into that balloon, and you can see very clearly there's flow almost completely redirected to the prostate with no flow down to that other branch. So I think we're very comfortable embolizing from here. We've already mixed up our embolic. You guys use this as well. So this is a 10-to-1 dilution, which we're gonna grab from the side table. Let's grab one or two syringes of the liquid embolic and then one of the water. So
you guys make this look easy, but honestly, that distinction with the balloon up versus down is critical here, right? Like it completely changed the flow dynamics.
I mean, that's one of the reasons why we like to use this. There's other reasons as well, but this is one of the major reasons, particularly when we see branches like that, so we have optionality to use the balloon or not use the balloon. But you're also going to see how deeply we can penetrate this embolic, which is going to be, I think, super helpful here.
And just a tiny point, but for users who are not doing this that often, especially from the radial, just the fact that you didn't add a TUI here, so you have a lot of extra working length here, but that's something that also gives you additional length.
So this is 150 centimeters total, and this is 130 base. So we don't have a lot of room here, so we don't use a TUI here. Also, before we actually inject anything, what I'm going to do is I'm going to put that deflation syringe on the back here, and I'm going to lock it. Okay, so this way when we're ready to remove the catheter, we can just flip the switch and the balloon will deflate very rapidly. All right, so while we're doing this, you guys can start chatting about our technique if you want. Sid's going to flush the catheter with a little bit of water. This is a full 3C syringe of D5 water. Yeah, go ahead.
This is something I'm always struggling with, what your dilution is, because 1 to 12 seems like there's barely any glue. 1 to 10, you're looking at like 8%, 8 a little bit percent glue in the compound. Is it all Lipiodol? I'm using 1 to 6 currently, but sometimes my penetration's not as good. It depends on the vasculature. If I have a really atretic or narrow vascular that I don't feel is going to take a lot of glue, I'll increase my dilution ratio to the 1 to 10, but I try to start at 1 to 6. And I don't know the answer here, and I don't think anyone has really determined the difference. What are your thoughts? Like,
yeah, I think somewhere between 1 to 8 and 1 to 10 is nice. I think if you go higher than that, it's almost all Lipiodol. So while we're chatting, Sid's gonna inject this at a medium speed, and we're gonna sort of see the glue come out. But you're gonna see this is a 10 to 1 concentration. I like this because it seems like it's the Goldilocks amount. You see how it's sort of just penetrating very, very nicely into the gland itself. Now we're watching as we inject. Okay, so we're gonna stop there. So you see how it penetrated a little bit down into that rectal branch, which is not atypical. So basically what happened here is we filled the actual prostate tissue, and as we were filling the prostate tissue, that tissue became high pressure, and so it redirected some of the flow away from the prostate itself. And so when we see that, it's almost like we coiled that vessel. It's not going to have any real issue for the patient. And so as we sort of wait here, we're going to wait for that to solidify. Then we're going to deflate the balloon, which is what we're doing here. And you can see now you see antegrade flow again.
To decompress, solidify, you also decrease the pressure head.
Yeah, exactly. We can put a little bit more here on the way out just to create a little bit of a proximal plug. Just drop a little bit here, right there. And now we're going to remove this. And so I sort of shake the catheter a little bit. You can see there's a little bit of glue stuck on it here. And now it's off. And so now we can actually remove this all the way, and we're done with that side. So that's a pretty fast embolization, as you guys know, that this shortens our procedure time quite a bit. There's no particles. We're not injecting a lot of contrast in a patient that has CKD. And so we've used, at this point, only 10 to 15 cc's of contrast, and we're done with one side. Our fluoroscopy time total is 4 minutes so far, and so we're pretty happy with that result. Now, there's lots of things that we can talk about here. The first is going to be collaterals, and as you guys sort of comment on what we just did, we're going to take another picture. So let's go over the technique a little bit. What do you guys think about how distal we penetrated that before we saw that non-target branch?
Yeah, something I wanted to bring up about that was that sometimes what you can do if you're not using a sniper, for example, and some places don't have access to sniper catheter, so something that you can do is you can actually select more distally into the more medial branches and use your flow to inject the glue into that central portion. And then as you're gluing that out, you can kind of pull back and you can get a pretty deep penetration. And you don't necessarily need to have the sniper catheter to do that for people who want to do this and want to get the deeper penetration and don't have access to a sniper catheter.
When you're using versus not using a sniper catheter, Art was asking about dilution. Are you adjusting the dilution of your glue?
I think this is like the art of it, right? It also depends on how fast you're injecting the glue or how slow you're injecting the glue and how big the prostate is. What is the patient's cardiac output?
That's pretty good.
And I think that has a difference in the polymerization rate. And then, of course, in the US, it's very different from overseas where they have other glue products where the polymerization rate and the exothermic reaction is much less with things like Magic Glue or Glue Brand. And so that's something to consider. So in the US, we're using mostly Histoacryl or Trufil, which has a much faster polymerization rate. And that's why I think a lot of us tend to use a little bit more of a dilute glue concentration versus overseas, they use a much more concentrated glue concentration. So that's just something to consider when people are looking at some of these references online, that the glue compounds can be different.
Everybody keeps talking about penetration and getting deeper into the gland. Why is this important?
Because we have a score.
Art, you want to talk
Fischman
about
and
that?
I work together. We have a scoring system that the deeper you are, if you get to the middle, it's like a grade 3, and that shows us those patients actually do better over time. We looked at this out to a year. But I want to say on the back table, are you guys cleaning your sniper so you can reuse it for the other side?
Yep, we just prepped it again.
Yeah, we flushed it very quickly with D5 as soon as it came out of the patient. A couple of times backloaded it with the wire to try to clear out
After we
as
wire
much.
it, we flush it again.
And then flush again with
and
D5.
then that allows us to pass the wire without having to worry about any liquid embolic that's stuck in there. It's not going to behave like it does on the first side. So while we're chatting, Sid's going to go down to the opposite side. But I wanted to show you guys the final angio. And you can see here the prostate artery is completely occluded. And now what we look for on these follow-up angios is collateralization to the prostate. And the most common areas that we look for are the distal pudendal, which is the recurrent, or the what some refer to as the pinna cava. There's nothing there, mostly because that artery is pretty diseased. Also, we look at the umbilical and the superior vesicular supply, and sometimes we see collateralization, particularly to the middle part of the gland in those scenarios, which we don't see here as well. We're also missing the obturator, which we know is replaced, and you can sort of see it as we scroll through this angio. You can see it off the external. So we could take a look and see if there's any alternative feeders, because we don't have a CTA. So we may want to do that before we go to the other side. Maybe we'll just do that before we go to the other side. We'll just hit that external real quick. So it's going to pull that catheter back a little bit and then just puff it down with a little bit of contrast. We can even just do the run almost right here, actually. That's probably fine. See if you can drop the catheter into the artery itself. So right now we're in the external, you can see, and then we're gonna ultimately find that obturator off of the inferior epigastric. Might be a little bit higher.
Yeah, and Aaron, I think that's a really important point to investigate the replaced obturator. I think that's a very common origin for these prostates, especially if you get like what's called the empty pelvis sign, where you do the hypoangio and it doesn't look like anything's going to the prostate. And if you don't see the obturator, it's a good indicator that it's probably coming off of a corona mortis.
Good.
So what we see here is not atypical in somebody with a pudendal artery occlusion. So I'm going to draw a little bit on the screen because it's sort of fun. Here's your epigastric right here, going up. We all know this from all the bleeds that we do. Okay, and then this is the corona mortis variant, which shows the obturator coming down and supplying not only the obturator territory, but if you look closely, it's actually supplying pudendal territory. And you can even see the cavernosal artery coming off the obturator here, which is pretty cool. We know that that's significant because the patient had a very diseased pudendal artery. And so that's why we see that. But we don't see any prostate artery supply, okay? And I don't think you need a cone beam CT to determine that. It's very clear based on these images. Now, if you wanted to, you could go to 8P and double check, but we don't see anything going in the expected location of the prostate. Keep in mind, this patient also has a Foley balloon, but we elected not to put contrast in the Foley balloon. We just wanted to do it without any obstruction in terms of our visualization. So sometimes we do that. Do you guys, in patients that have catheters, do you guys replace the saline with 50-50 or something like that?
Not anymore.
I don't mess with it.
We used to do that back in the day, but we don't do that anymore.
You know, Aaron, while you're working here, you mentioned cone beam CT and using cone beam CT. I know, both are moderators and you are very well experienced. You do a lot of prostate artery work. Did you ever use cone beam CT? Can you talk a little bit about the benefit of using that when you're starting earlier on?
Well, I'll just tell you, I use it when I need it. I know that there's some people on the panel, one in particular, that might disagree with me on that, and that's fine. We like to use cone beam CT as a problem-solving tool when we need it, but I personally like to use anatomic landmarks and anatomy patterns to try to understand what we're dealing with as best I can. And so if there's a situation where I don't know what vessel I'm in, I will use cone beam CT. I also like it to look for complete coverage of the gland itself after we do an embolization. So sometimes we'll use it for that purpose. but I don't use it to find the vessels. I think there's lots of different anatomic. Let's look up the injector. There's a lot of anatomic landmarks that I think make a lot of sense, and I try to use the patterns that Dr. Carnevale came up with in terms of the types of anatomy, and then potentially where you're going to see the collaterals. And so we know all the common locations of collaterals, and unless you have a patient that has very severe PAD, you're going to see those patterns in almost every patient. This patient has some atherosclerotic disease, but no occlusion so far. So I don't think we're going to see any weird aberrant anatomy, but you never know. As we hook up the injector, now, Art, Jeremy, what do you guys want to comment about cone beam CT just to answer Dr. Garcia's questions?
I think he was referring to me. I don't use cone beam CT to find the vessels. I do check before to see if any small collaterals, most likely they're clinically insignificant. That does increase my dose. I don't do a pre-op CT angio to plan, so there's a give and take there in that space. I think also, I just want to break a point up. Dr. Fischman's using a 40-degree ipsilateral. I typically do the same way every time, 30 over and 10 to the head to make it easy the same way every time. So that's just another comment that I wanted to make on the technique. But theoretically, if you know where you are, you can recognize all these things. We recognize it. Just everyone on the panel knows that I'm a urologist that's done 2 IR fellowships and credentialed to do IR. So sometimes I lean on the side of good documentation to avoid if someone's going to say, well, he was in the wrong place. What does he know? But it's been 25 years of my experience with PAE to date, which is somewhat incredible. So it's kind of funny. I feel old now. What do you think, Jeremy? Not me being old.
I think, well, yeah, you are old and I'm younger. So I think for those who are younger and they're starting out in this, I do think using cone beam CT is probably a smart way to go. Me personally, I kind of am like Aaron. I use it more of a troubleshooting technique for troubleshooting purposes. And some of my patients travel from afar, so it's not always feasible to get a CTA ahead of time. And so a lot of my patients don't have CTAs coming in. I think as you develop more experience, you kind of understand the patterns of the anatomy. And I think that it probably isn't required necessarily for every case, but it certainly is helpful to have in those situations when you're having a little bit of trouble identifying what the anatomies are, or when the glands are in particular smaller. That's where things can get a little bit more challenging and difficult to understand what's happening.
I'm going to show you guys a couple of things here before we put the microcatheter back in. This is, very similar to the opposite side. We don't see an obturator artery, but what we do see here is a diseased pudendal, right? Let's see, free draw. Okay, this is the diseased pudendal, and actually it's back here. Sorry, that's the rectal artery, or one of no, actually that's pudendal. Sorry. Okay, so then here's the prostate artery, as we very obviously see here. Very big. It's always in these large prostates. It's usually the largest artery on that side, and then one of the branches back here is going to be the rectal artery. If we follow that out, that's going to be the middle rectal. And so the biggest question that I have on this angio is not what this is right here, which is obviously supplying the bladder, and I'm going to ask you guys to comment on this. What about these two branches here? There's this branch that comes down, which is supplying a good portion of the prostate, and then there's this branch a little bit higher right here. And so we're going to get into it and see, but just something to keep in mind. How would you classify those two branches, guys, in terms of which one's which? But I think they're both going to the prostate, it looks like, on this angio, but we'll double check. All right, let's do that. What do you guys think about that?
I think whenever I see a diseased pudendal in general, I always am a little bit more cautious about what I'm looking at in terms of the prostatic artery, because there's usually always a collateral that goes to the penis then. And so whenever you see that, I think people need to be a little bit careful when they're looking at the prostatic and look for those shunts, those accessory shunts that go to the pudendals, and make sure that they're not going to inadvertently have non-target embolization. But to answer your question, I think the superior one is probably more of the anterolateral central gland branch, and the inferior is probably going more to the posterior base of the gland, is my suspicion. But I think both go to the prostate gland. I'm curious to know, when you see this, Aaron, do you try to selectively go into one versus the other when you're knowing you're going to be using glue? Because you can't as easily reselect and kind of go back down when you're using glue. Or do you try to stay proximal to all of that?
Well, that's a good question. I think a lot of it's going to depend on what we see when we get into it. you know, it's a little unclear based on that oblique image, but we'll probably do an AP as well. We have a wire in the in that bladder artery here. We're going to try to redirect it a little bit posterior into the main trunk.
How's that catheter
It actually
performing
might
now that
be.
you've used
I
the
think
glue
it's
already?
maybe a different
separate
It
origin.
feels
separate
fine.
origin.
It's, you know, you got the key thing is to get it out and flush it quickly. You know, with a 10-to-1 concentration, you have the ability to do that.
Right, it's doing like a tight.
But you have to, you know, you
up
can't leave it in
first.
for, you know, for 30 seconds and then expect to be able to flush through it.
There you go.
There we go. All right, so Sid was able to get the wire past that bladder artery, and now we very easily can just sail it over there. So you guys wanted to just do another run here. So I think probably what I'm going to do is I'm going to stop here, and we're going to go to AP. I think that'll give us a little bit more information. And so I'm trying to minimize contrast on this patient. We've only used about 15 cc's so far, which is fine. But again, you know, cone beam CT is another thing that uses contrast, and depending on how you utilize it. And so we're probably not going to do that in this case unless we absolutely need it. So I'm going to take a look here. We're just going to do a quick little 3 cc contrast injection, really 70-30. Just puff a little bit before we do the run. Okay, so it's sort of looping around. I think I'm going to go back to that oblique. That shows it a little bit better, okay? Yeah, that's what we suspected. Yeah, so we're filling even the part of the tissue on the right side that we didn't embolize. And so that, you know, some patients, as you guys know, will have the majority of their supply, sometimes 2/3 from one artery. But both of these arteries are very clearly going to the prostate. I don't think there's any doubt about that. One of the things that we're looking for on that bottom branch is whether there's branches exiting the prostate and going to the penis, which we sometimes see. Before we put the balloon up, since we have the sniper, we're going to put some more nitro in just to make sure that we give ourselves the best possible chance to get as distal as possible. What would you guys do here? Any comments?
I was just going to mention about the contrast thing. With someone's CKD, would you ever consider using CO2 for your iliac runs?
Yeah, you could, but we really used, I mean, for the iliac, you mean for the actual internal iliac run or higher up?
Either.
I don't think I've ever done that. We could if we were really concerned, but the amount of contrast that we're using is just so small. I don't think we've even used, you know, more than 20 at this point.
How much nitro are you giving, Aaron?
So I just gave a little bit more. This is about 300 micrograms that we just gave, and another 2.5 of verapamil. I mix them together in the same syringe, so it's a little bit more efficient. We're going to wait a second before we do the run just to let it do its thing, and then we'll do another run. So I'm going to do 2 more runs. Now I could save it, and I could try to do it with one, which we can talk about, because I want to put the balloon up, but I also want to see the difference between the balloon up and the balloon down. I assume it's going to help us, but sometimes when you put the balloon up, it actually redirects blood flow into a place that you don't necessarily want it. So I think what we'll do is we'll just do a run with the balloon down first to start, and then we'll go back and do it with the balloon up in a second. And I like this view too. I think this view is really nice to show. Oh, actually, it redirected the blood flow sort of at the bottom part of the prostate, if you guys notice. And it might change actually once we put the balloon up. So that was just the difference between giving nitro and verapamil versus not. And you can see most of the blood flow now is going to that inferior branch. I don't think it's going to make a difference with the balloon up because it's going to be able to inject and pressurize both vessels, but we'll see. What do you guys think about that? Let's put the balloon up.
I'm a big fan of looking at how the nitro flows out of the end of the catheter. So whatever's left in my catheter before the nitro, the contrast that I flush through, I try to look at where the distribution's going and adjust my pressure. I think that's really key to understand the whole process here.
You want to get on that?
I think what's interesting is that you manage that sniper wonderfully into those vessels. I think that was really impressive, especially the second time around, because sometimes the balloon, you have to be careful when you take down the balloon because you did that negative pressure, so it's a quick extraction. It could have a little fold in it, and then it won't leave the penumbra. So I think you managed it really well.
Thanks, Art. Sid and I were just talking about whether we should put this catheter a little bit further in. I don't think we need to with a balloon catheter because we know we're going to get both branches. But if we were using an end hole, we would potentially advance it into each of those branches. I don't think that we're going to maneuver this catheter anymore because I think it's in a good spot, and we know we're going to be able to get both of those branches without any non-target here. So the next step, if you guys want to focus a little bit on the hands over here, my hands, I want to show you guys how little contrast or 50-50 contrast saline we need to actually get the balloon to inflate. And so this is a syringe that has 0.25 cc's in it. We're going to use very little of this, and so you're going to just watch the live fluoro as we do it, and I'll zoom in so you can see. And there's a big contrast column too. So what that means is we probably have some spasm at the top of the vessel, but you can see the balloon right there. Now it's occlusive. And so that was about half of that. So that was probably 0.12-ish. Not very much at all. Okay.
I think the phenomenon that you're witnessing is important when you're using a liquid embolic. If I see this, I back up my diagnostic if it's wedged in there, so I have that ability of any forward flow to keep the glue from refluxing. And also, it's of note when you do use glue and you inject and do a run quickly afterwards, if you're using your base catheter, understand that the glue is the contrast is non-ionic, so you could end up displacing your glue. So be careful with that as well.
Yeah, we have a nice column there with all that. I'm gonna inject very hard because I want to see the collaterals, and you can see when we inject very hard, we fill all that top branch. But I wanted to do that to make sure that there's nothing going south. And then there's still sometimes, even after a good run, and we include these vessels, you're going to see that some collaterals could potentially open up here. But to Art's point, if we go back to the fluoro here, there's a big contrast column between the balloon and the base catheter, but the base catheter is very high up in the vessel, and so we're not gonna reflux past that. I could have flushed the catheter a little bit to differentiate the two, but I think we can see very clearly the difference between that contrast column and that balloon there at the bottom. You guys can see that pretty well? Mm-hmm. Yeah.
And vice versa, if you don't have a sniper balloon catheter, you could use this technique as a way of flow occlusion rest type technique too, as an intermediary.
All right, so we're going to inject some water here to start. Do you guys like our position, or would you move it?
That's a good question. I think we know that the most symptomatic component is going to be that central portion. So I could see the argument if someone says like, hey, you should go for the superior central median gland, but I think you're in a great spot and you got your sniper there. So I don't think you need to move it personally, but.
Yeah, we're going to inject a little bit faster on this side than we did on the other side because I think we feel pretty safe in this location. So we're going to go pretty quick. We're going to try to get it to perfuse that middle branch or that superior branch that's going to the middle part of the prostate. And so this is a sort of a two-handed or four-handed operation. There we go. Beautiful. Beautiful. And that's it. So we're basically done. We filled both of those branches. We got, as Art would say, level 3 perfusion. Maybe we can tap a little bit more in if you want. We have another syringe here just to see if we can we can push a little bit more in, but I don't think we need to. Do you guys think we need more penetration than that? I don't think so. So tap it. Let's just see what happens. Okay, that's good.
Yeah.
But there's your branch going outside the prostate. See, that's what I was talking about before. And so the nice thing about balloon occlusion is you can actually let the balloon stay up until that material just stops moving because it's sticky, much different than other liquid embolics that are not sticky. And that's one of the big things that we love about n-BCA is it's sticky. And now I'm going to take the balloon down. You know, it's a plus and a minus, right? But in cases like this, it's helpful. And now we should be able to just get that catheter right out. And there's no glue stuck on the catheter. We just sort of inspect it visually before we pull it. We don't want to drag any glue back that's stuck on the catheter. So I'm just sort of looking at it really and moving it around, making sure. And that's it. So it came out. No issue with catheter sticking or grabbing glue if you're careful, but you do have to be vigilant because one of the downsides of using an adhesive agent is that you can pull some of that glue out and into the other branches more proximal, which would create non-target embolization. So before we finish some of these discussion points, I'm going to just do a quick run in this view because we're already in an oblique view, but I really like the way that looks, at least on the oblique. And so what we're looking for on the follow-up run is not necessarily the prostate artery because we know that that's for sure occluded, but what we're looking for is collateralization. And so we're training our eyes to look for that. We can see the pudendal branches and we see the pudendal blush there, We don't see anything going superiorly to the prostate. It's pretty amazing he has that good pudendal blush at his age, right? 89 years old. But nothing coming down from the superior vesicular artery. This looks like a complete embolization. Do you guys agree?
I agree.
Me too. You're gonna do an AP shot to
Right.
be able to grade our penetration in the AP.
So as Art mentioned, we like to sort of see one picture of the penetration. And so, I think on the right side, we probably have 2, and on the left side, we probably have 3. And I use the midline, right? Art, do you want to sort of walk us through what we're talking about here? I'm going to draw a line right through the midline on the screen here. Let's see.
In the beginning, we did the cases, and then patients would come in, are they going to have a good response or not? And then we're able to hey, I think the degree of penetration really matters, because in the beginning, you may not get great penetration, and we call that a level 1 when only the main PA is occluded. 2 is like halfway across the central gland, 3 is all the way to the midline. And then you can have different degrees, which I did not differentiate when we did our original paper because we didn't see a clinical difference in those groups. But we have grade 1, 2, and 3, and 3 is our best, and we kind of use that as a summary. The only groups that really do poorly are the 1 to 3 total all score. So if you have a 1 and maybe a 2, you're not going to have as great as a result as anything about 4 and higher in that group. So we try to really break this down. I love this machine that you have, Fischman. Like, this is amazing.
Yeah. How many crayons?
I come and I'm jealous. Like, the picture looks amazing. What's your dose so far for this case?
Yeah, so I was going to mention that in a second, but do you want any more colored lines on the screen, Art, or can you describe it with these 3 colors that I have here?
No, I can do that with the 3 colors. Basically, if you're just up to the blue lines, that's really a 1 between blue and green. Then the green between green and the orange is a 2. Once you get to the orange line is essentially a 3. And there's some understanding of what the vascularity looks like in an 89-year-old prostate as well. So he's shown us our 3 grades of this. I would say the right is definitely a 2, and the left is more like a 3, but that central median lobe area is a little underpenetrated on the high side near the base of the prostate on the left a little bit. But he's 89
on the right,
and he's a vascular patch.
On the right, we had to stop because we saw perfusion of that rectal branch, so we didn't want to get any more distal than we did, which that's one of the downsides of having a sort of a proximal embolization where you're trying to occlude the entire artery with branches that are more proximal.
But if you're using particles, you would never recognize that. It would have flowed through to the penis the whole time.
Exactly. That's one of the reasons why we don't like particles anymore. We do think that liquid embolics, particularly adhesive agents like n-BCA, are safer if you have experience using them, because we have the ability to sort of start and stop our injection with our hand, as opposed to particles, which are entirely flow directed. So to answer your question, our total fluoroscopy time is 10.2 minutes, which is good. We've done better than that, but that's pretty good. I'm happy with that. And then our dose is less than a gray. It looks like 951 milligray. So that's a pretty standard. I think that's pretty standard for our experience now with n-BCA. What do you guys think? What are you typically getting with fluoroscopy times and dose with glue?
Yeah, it's much faster. I mean, 10 minutes is for standard anatomy. I think 10 minutes is a great time. My personal record I've shared with Aaron is 6 minutes, but yeah, it's much quicker than having to sit there and watch and do the particles, and I think most people can understand that concept.
If you're under 7 minutes, Jeremy, that's crushing it. That's great. That's like the sweet spot, to get in there and get it done on both sides. I only usually hit those types of numbers in my younger patients. Like an 80-year-old patient, a 90-year-old patient almost, 10 minutes of fluoro time is amazing, especially with that patient's vasculature. So kudos to Dr. Fischman to show off today.
Well, there's a couple of things that help out here, and I wanted to just review that before we finish. I think radial access, as you guys can see, is faster than femoral with people that know how to do radial access. There's no question about that. We've seen that in clinical studies as well. And the reason is because, with the exception of navigating through the arch up top, it's easier angle-wise to get into the internal iliac arteries. And then you don't have to do any sort of flipping. We're going to center on the wrist while we do this closure, just so you guys can see. Let's see if we can zoom in on the wrist. We're going to show you guys the TR band, and people who don't use radial access will just show that. So I think radial access helps with our fluoroscopy times. Clearly not having to fluoro while we inject beads is critical. And so that probably halves our fluoroscopy time, because the majority, at least in this case, the majority of that fluoro time would be watching our beads and making sure they're not going into non-target areas. And so the visualization that we get with glue really shortens, and obviously the speed shortens our fluoroscopy time quite a bit. So Sid's going to just put 15 to 18 cc's of air into the band. We're going to take the sheath out, and he's going to just slowly deflate the band until we see a little bleeding. That's one way to do it. The other way is to put your finger over the ulnar and wait for a pulse in the radial. And when and it's right about the same time he sees a little bit of bleeding. And so now we're going to just put a little air back in. So that's about 10 cc's of air total. And the other thing I wanted to just show you guys, if you look at his wrist, and then this is an important point for radial access, here's his styloid, okay? If you look at the distance from the styloid to where the forearm becomes a little bit thicker, we like to sort of go somewhere in the middle between these 2 points when we do our access. This is a little bit lower because we weren't super concerned about his height, but you can go a little bit higher in somebody who's a bit taller. And so we don't really have these height limitations that we used to have, particularly when we use the 130 penumbra catheter, which has been my favorite as of late, because it gives us sort of the best of both worlds in terms of flexibility, distance to the artery, and all of that. So that's the entire case. Pretty quick. Really wanted to show this just because we've done this case before for our treat symposium. We can switch off the arm if you guys want and go back to the fluoro. If anybody on the panel has any questions or points that we should discuss, we have a few more minutes before we can close out. We're almost at 10.
Erin, I just wanted to comment a little bit about what now. What's your follow-up for this patient, both clinic-wise? What medications are you sending them home with, and what's the plan for the Foley?
Yeah, so we mentioned somewhere between 2 and 4 weeks. I like to see them back at 2 weeks, and if the catheter is recently placed, which in his case it has been, we should be able to get it out at 2 weeks. But sometimes we wait till 4, particularly in patients that have been catheterized for a little bit longer. But I think somewhere between 2 and 3 weeks, we're going to bring him back and we're going to do a trial avoid. And I would be pretty optimistic, at least based on our findings here, that we're going to be able to get that catheter out. And based on the literature, we've seen many studies on this. 80% of patients can have the catheter out by 4 to 6 weeks. And that's been our clinical experience as well. I'm sure you guys probably see that in your practices as well. And then in terms of medications, everybody that we treat gets a quick 5-day steroid taper. We can add NSAIDs if we want, but we like that as our primary anti-inflammatory. And then we will often give pyridium as well for people that have burning. But honestly, patients that have catheters are already bothered by the catheter, so I'm not sure that the pyridium is going to help too much. And then the other thing that we like to give is antibiotics. I know there's some debate about that. Do you guys give antibiotics for a week or 10 days after embolization, typically?
I do like a 3-day course.
If you're not touching the urinary tract, you really have no manipulation. There shouldn't be a long-term course. Like you can do a 24-hour, you give a dose during your procedure, but I've never been using any antibiotics after the procedure unless the patient has an active UTI that we've treated right before the procedure to extend through. However, I rarely use that. And the steroids for me, older patients, because of confusion and stuff, I have a modified taper if needed. Otherwise, I try to stick to the NSAIDs unlike this patient that cannot tolerate NSAIDs with CKD, I try to lean on less is more in these areas.
Jeremy and Art,
catheter-dependent patients, I think, are sort of the one scenario where, particularly when they come in with catheters that are from the community, we sometimes will see very resistant E. coli that grows in some of these patients. And so even if you give something like Bactrim or Cipro, you might not even have any efficacy. So there's not a lot of evidence suggesting that antibiotics are useful here. Most people, I think still give them. It's sort of one of these things that make us feel comfortable, but we're not really sure that they work. What were you going to say, Kirema?
I was just going to say, Jeremy or Art, any last minute comments in terms of follow-up?
Yeah, I had a question for you guys. So what do you guys do with the patients that come in for a trial avoid and they fail their trial avoid at 3 to 4 weeks? I think that's not uncommon. If you say 80% success rate, still 20% of patients aren't getting their catheters out. What's your discussion like with the patient at that point in time? What do you do then?
I'll do another 2 weeks, Jeremy. I'll wait till 6, and if we can't get it out at 6, then at that point, I'm going to be a little bit more more pessimistic for the patient and not optimistic anymore, because I think after 6 weeks it can be challenging. I've had a couple patients after 6 weeks and we wait another 2 weeks and we've gotten it out, but it's, you know, generally between 2 and 6 weeks you should be able to get the catheter out. And so if you're not out by then, that would be, you know, in my view, maybe a treatment failure.
I typically give them a 2-week chance to urinate and a 4-week. If they, at that point, at 4 weeks, if they fail, I teach them how to catheterize themselves, and then they track their volumes over time. What their residual is when they cath. If it's less than 200, we get to a point and they have good kidney function. I was like, we'll continue to track the PVR and flow over time.
Great.
Yeah.
Well, I think it's 10:02, so thank you, Aaron, Sid, and Vivian, and special thanks to both Jeremy and Art for being here today. Great case and great discussion. So, and everybody who's watching, we'll see you next time.
Thanks, everybody.
Thank you.
Thanks for joining us and tuning in.